of the body, and it's appropriate that these should be handled by the general internist. My takeaway message from you today, so if there's just one thing you remember, is that the newer anticoagulants, the novel oral anticoagulants that are not so novel, so we call them direct oral anticoagulants, are generally safer than the older ones that we refer to as vitamin K antagonists, such as warfarin. That's the first point. And the second point is that not all direct oral anticoagulants are the same, and some, in fact, may be safer than others. So let's get started and start with the case. Here's a patient who typically presents with deep vein thrombosis without any associated risk factors and is considered having idiopathic thrombosis. And you will see that when we decide about how to manage long-term treatment, do we continue anticoagulant therapy? There are several factors that play into this decision. And some factors are associated with a lower risk, like if the patient has an antecedent risk factor. But in a patient like this, who's a male, who has unprovoked thrombosis, and let's say they have a D-dimer test that some people do use after anticoagulation, these are factors that increase the risk of recurrence, which leads us to ask, should this patient be on indefinite or long-term anticoagulant therapy? The guidelines, in this case from the American Society of Hematology, suggest indefinite anticoagulation over stopping anticoagulation. This is a conditional recommendation, which means it may vary depending on individual patient circumstances. And yesterday we heard a lot about how the society here is very patient-centric. And there's no better area to practice patient-centric medicine than in thrombosis. There are a number of prediction rules that help the clinician determine the patient's risk for getting another thrombotic event versus their risk of bleeding while on anticoagulant therapy. This is one that looks rather complex, but actually is very informative because it takes into consideration both of these factors, so the benefits of treatment and the risks of treatment. And when we summarize what this guideline prediction rule tells us, you'll see that it provides the benefits and risks with each treatment approach, whether it's with a vitamin K antagonist, so it's good in terms of prevention, but high in terms of bleeding. The aspirin, which has some benefit in terms of prevention, not as good, but lower risk for bleeding. And then the direct oral anticoagulants at a full dose. And it appears that the sweet spot, so to speak, is with the lower dose direct oral anticoagulants that minimize the risk both for recurrent thrombosis and bleeding. However, we also need to take into account patient-related factors, bleeding risk, lifestyle factors, and costs, of course, that come into the decision-making at an individualized, patient-centric manner. These are two options that have been studied for long-term secondary prevention of recurrent venous thromboembolism, and you'll see that they have very good efficacy and safety profiles as compared to placebo in the case of apixaban, as compared to aspirin in the case of rivaroxaban. So let's move on now to a more complicated situation, and that involves whether we should be using thrombolytic therapy, which in general we don't use very often, and it's something that we sometimes need to know about because there may be circumstances where, as internists, we are called upon to decide, does this patient need a more dangerous potentially or therapy such as active thrombolysis? So let's consider a young woman, and both of these cases are real cases, by the way, that comes to the hospital after a syncopal event. You can see by the clinical picture that this patient is quite ill, anxious, dyspneic, and her parameters are sort of on the borderline. She's not quite in cardiogenic shock. She's very tachycardic, and she's requiring a fair amount of oxygen to keep her saturation at a low level. So is this somebody that we would consider thrombolytic therapy? And you'll see that there's clots in both of their main pulmonary arteries. and that her right ventricular size is quite enlarged. That should be about 1 to 1.7, and you see it's kind of flipped. So the question is, should we be using thrombolytic therapy to reduce the clot burden to improve outcomes in this patient? What the evidence tells us from large randomized trials is that in patients who do have evidence of hemodynamic instability, then yes, you should proceed probably with thrombolytic therapy. If that is absent, then you should avoid thrombolytic therapy. But this patient falls into this middle category where they're not quite in hemodynamic instability or cardiogenic shock. Maybe they'll improve a little bit with fluids. And here things are where they are really kind of fuzzy and where the clinical judgment of the internist is most important. And in fact, when you look at the guideline recommendations, what they will suggest is, first of all, thrombolytic therapy is not routinely recommended in patients like this who have intermediate risk of pulmonary embolism, but it should be considered if they have cardiogenic shock, or more importantly, as rescue therapy. So the importance of this type of patient is if you're monitoring them closely and they are on a downward trajectory with more deterioration from a cardiovascular or respiratory standpoint, then these guidelines justify pulling the trigger, so to speak, and administering a lytic therapy on top of the conventional anticoagulant that you've just started. So, important case that illustrates how clinical judgment, and in this case, what the trajectory is. By following the patient closely, you determine the need for lytic therapy. There are various regimens that can be used, whether tissue plasminogen activator, TPA, over 2 hours. You can modify that dose. That's another thing to note. The internist is able to take these drugs and play around with them, so to speak, and modify their dosing according to the patient. This is what we can use if the patient, maybe they had recent surgery and they are at high bleed risk. What if they come in the hospital with a cardiac arrest? And if you really need a fast effect, there's a different lytic therapy tenecteplase. And in patients with deep vein thrombosis that is massive, that involves the iliofemoral vein, here we do have randomized trials, but in general, the use of lytic therapy should be limited to a specific subgroup of patients who have extensive thrombosis, recent symptoms, good functional status, and low risk for bleeding. And there are new technologies being developed that are used in conjunction with lytic therapy, mechanical methods to remove a clot and to administer lytic therapy at relatively low doses to prevent, in this case, the important complication of the post-thrombotic syndrome. Thrombosis at unusual sites. Can we use a direct oral anticoagulant? These are clots that when I started in my career were not as common because we did not have as much imaging done of the body. And these clots are often asymptomatic but can be substantial in terms of the potential clinical impact. This is one situation. We're doing echocardiography a lot, and we're seeing a lot more patients that have ventricular thrombosis, often asymptomatic, but important to treat to prevent embolization and stroke. These data are observational, from observational non-randomized studies, but suggest that a direct oral anticoagulant may be as effective and perhaps even safer than a vitamin K antagonist. Another situation which is also not uncommon, cerebral sinus vein thrombosis. And just as a quick aside, these are patients that often have a hemorrhagic component, but they do require anticoagulation because the hemorrhage is actually as a consequence of the thrombosis. So you do anticoagulate them, and this meta-analysis demonstrates that, once again, DOACs appear to be safer than vitamin K antagonists and associated with a comparable functional outcome in terms of neurological symptoms. So once again, we can consider using a DOAC in this situation. Splanchnic vein thrombosis really has become very common because of imaging is done more so for patients with abdominal symptoms or for cancer screening and progression. And the one message here is that often in patients who may have cirrhotic liver disease, anticoagulation may not be necessary because these are chronic fibrin-rich clots that the anticoagulant may not do too much. But in those situations where the clot is newer, then once again, anticoagulants with a DOAC seem to be associated with a reduction in bleeding compared to the vitamin K antagonists and a good functional outcome, in this case, based on clot resolution. So another situation where we might consider a direct oral anticoagulant. Now, having said all that, the default management for all these unusual thrombi will still be vitamin K antagonists, usually with a lead-up period with a low molecular weight heparin or an unfractionated heparin. So that still remains your default management. But more and more, we are using the newer direct oral anticoagulants for management of these patients. Now, anticoagulants, as you know, are drugs that have relatively few side effects. But the main side effect is, of course, bleeding. So we need to be able to deal with that if it occurs. And this is an important consideration, as I said earlier, in terms of clinical decision making. So what do we have in our therapeutic armamentarium to deal with bleeding? Well, we have a number of products. These are blood products. These are prothrombin complex concentrate. And they are focused on the vitamin K dependent factors 2, 7, 9, and 10. So they are ideal for patients who have a bleed while taking vitamin K antagonists such as warfarin, but we're using them increasingly in patients for bleeds associated with the DOACs. But they are very expensive and not always widely available. And even more expensive are the specific reversal agents for the DOACs. This is adairusizumab, which is a specific agent targeted toward the reversal of dabigatran. And this is andexanet alpha, extremely expensive medication that is highly restricted, that is used to reverse the effects of the oral factor Xa inhibitors, such as apixaban and rivaroxaban. A less expensive medication that's really made a resurgence in the last decade or so is the antifibrinolytic tranexamic acid, and there's a number of trials, as you can see, in various clinical situations where it has been shown that it can reduce the potential effects of bleeding, namely especially transfusion requirements. So this is something that is an old drug, but something that has had a resurgence. Now, the question is, will it work in patients who have anticoagulant-related bleeding? And unfortunately, most of the data that we have prospectively on the use of this drug is in patients who don't have anticoagulant-related bleeding. And here is a trial involving patients with GI bleeding, and it essentially shows that it didn't really do a lot in terms of reducing mortality and maybe increase the risk of thrombosis because of its antifibrinolytic effect. Similarly, another disappointing result in this study looking at patients with intracranial hemorrhage, but not anticoagulated, did not show showed a benefit in the outcome of volume expansion of the hemorrhage, but did not show a benefit in terms of neurological recovery. So this agent, although inexpensive, doesn't seem to work in non-anticoagulated patients. Can we use it in the anticoagulated patients? Sometimes, but only empirically. And here is an algorithm that sort of provides you with an approach to bleeding. In most cases of anticoagulant-related bleeding, the bleeding will, if it's a GI bleeding, will stop with supportive measures, saline, packed cells, and of course, if needed, endoscopic management. Fortunately, with intracranial bleeding, the damage has already been done and the prognosis is not very good, especially with intracerebral bleeding, and all we can provide is supportive care, although in some cases we do manage these patients with various anti-bleeding measures, including tranexamic acid. But really, what is the best way to treat bleeding in patients with anticoagulant therapy? The best way is to prevent the bleed from happening in the first place. So I'm going to come to that in a minute. But in patients who do bleed, an important question is, should we be resuming anticoagulant therapy? Most doctors are very reluctant to do this because they feel if they resume the anticoagulation, they will cause a bleed and they will be responsible, whereas if the patient develops a stroke or a blood clot, that is considered more divine intervention, but if they bleed, that is the doctor's fault. And I want to try to change that perception if it does exist, and that means looking at data such as patients who have had a bleed while on anticoagulant therapy. If we resume the anticoagulant, this data shows that yes, it increases the risk of bleeding, but it also reduces the risk of thrombosis in a significant way, and also reduces the risk of overall mortality. In intracranial hemorrhage, you'll see that it does not seem to have an effect on increasing the risk of recurrent bleeding, but importantly reduces the risk for stroke, which is of course a devastating complication that we want to avoid. So the message here is if after a bleed while an anticoagulant, your default should be, yes, I will resume the anticoagulant. And then that begs the question, when should we do it? If it's an upper GI bleed, it will depend on the etiology. In these cases, this is a self-limiting problem, a malleolized tear, gastric antrovascular ectasia, very difficult, and you may never be able to resume anticoagulation. And here is an empiric formulation that is anchored on the type of bleed, the source of bleeding, and when you can safely resume anticoagulation. For a lower GI bleed, a similar story. This is a reversible self-limiting bleed, whereas if you have an unresectable tumor, that may be an ongoing source of bleeding that you can do very little to deal with. And similarly, you have an empiric formulation about when to resume anticoagulation, whether it's hemorrhoids, diverticulosis, angiodysplasia, or an unresectable tumor. We get worried the most about intracranial hemorrhages, and these are not all created equal. As you go from subdural to deep intracerebral to lobar intracerebral, the risk for recurrent bleeding increases. Accordingly, we have to tailor the resumption of anticoagulation from as little as about one or 2 weeks after a subdural to perhaps 4 weeks after a intracerebral bleed, and maybe never after in cases with, let's say, amyloid angiopathy. As I said, the best way to treat the bleed is to prevent it. And the best way to prevent a bleed is to choose an agent which may be associated with the least amount of bleeding. There are emerging data from large administrative databases that when we consider the outcome of bleeding or gastrointestinal bleeding, it appears that the twice-a-day DOACs are safer than the once-a-day DOACs. So, for example, when we compare apixaban to rivaroxaban, there seems to be less overall bleeding and less gastrointestinal bleeding. So, to summarize then, what are the 5 top challenges? And I'm going to be about 30 seconds. Lifelong anticoagulation after idiopathic thrombosis, yes for most. Low-dose DOAC is the best option. Thrombolytic therapy, yes, if hemodynamically unstable. Unusual site thrombosis, yes, you can use a DOAC. Warfarin is still a sensible alternative. PCCs are first line for DOACs, but often supportive measures are adequate. And then, yes, we do resume the anticoagulant after a bleed, and the timing depends on the bleed risk. I'd like to thank you for your attention and remind you of the McMaster textbook of internal medicine.